All right, guys, we are moving up the body, and we are currently talking about the shoulder. So last week, you will recall, we covered the spine, and so we're now moving to the shoulder, and then our last lecture will be on the elbow, forearm, and hand. And so just as a quick review for bony anatomy of the shoulder, I think it's important to start with this slide here and to really talk about the relationship between the humeral head and the glenoid fossa of the scapula, right? And what we can see in this image, and what's extremely glaringly clear, at least to me, is how large that humeral head is in relationship to its actual receiving structure, right? So we have a head that's larger than the surface that it's going to sit on. And in some cases, that's a really good thing, right? Because what we know about the glenohumeral joint, it's one of the most mobile joints in the body. And the reason that we have so much mobility in the glenohumeral joint has to do with the fact that the glenohumeral head is larger than the glenoid fossa, right? But with that increased mobility comes a lack of stability about this joint. So in other words, it's easily injured, most often suffers from subluxations and dislocations. And so understanding that bony anatomy and that bony relationship between the humeral head and the glenoid fossa, it becomes instrumentally important as we begin to assess patients in our clinic who come into us with shoulder pathologies. So there are really two different types of injuries that can occur in terms of classification when we're talking about the shoulder joint, and those injuries can include injuries that occur by direct force. So what am I talking about there? A joint sprain, a dislocation, a fracture, maybe even a rupture of a ligament, right? And then we have these overuse injuries, which we're not going to spend a whole bunch of time talking about in this class. You'll spend a whole bunch of time talking about that in your evaluation of upper extremity class in the fall. But overuse injuries can include anything like impingement syndrome, strains, could include sprains, and certainly a dislocation could lead to several different overuse injuries within the glenohumeral joint. So these are just the different classifications of injuries that can occur in the shoulder. We're going to talk about the most common that you might see currently in clinical practice. So glenohumeral instability is a problem about the glenohumeral joint. And it has to do with what I mentioned on the outset as it relates to the anatomy of the glenohumeral joint, this idea that it's a ball and socket joint, right? The ball being the glenohumeral head, and then the socket being the glenoid fossa, right? That humeral head sits within the glenoid fossa, but because that humeral head is so large, we get a lot of mobility, but we sacrifice the stability of that joint to gain that mobility. And so in essence, it's not a true ball and socket joint. And the reason it's not this true ball and socket joint is because the ball doesn't sit deep within the socket itself, right? It's sitting on the outside of that socket. And so while we call it a ball and socket joint because one structure is rounded and the other surface is flat, certainly we know that because the glenoid fossa is smaller, that humeral head isn't sitting deep within the fossa. And so it's not considered a true ball and socket joint. Part of the reason that we say that is because it's lacking that bony or osseous stability. And again, that has to do with that relationship between the humeral head and the glenoid fossa. Now, maybe you guys are tired of hearing me repeat that over and over again, but if I'm repeating it, it's for an absolute reason. That we have to understand those two distinct features about the glenohumeral joint. And as you get into upper extremity and you learn more about the glenohumeral joint, you'll understand why the relationship of the humeral head to the glenoid fossa is extremely important. The other thing that we know about the glenohumeral joint is what is stated on this slide. So we have moderate ligamentous stability. We have moderate muscle stability. And then because that glenohumeral head is larger than the glenoid fossa, we don't have that stability bony-wise, right? So our stability really is inherent in all of our dynamic structures, our ligaments, our muscles, right? And less by the bony relationship between the bones that are articulating within the glenohumeral joint. And so I'd like to equate the glenohumeral joint to either like a golf ball on a tee, where the tee is a lot smaller, or if we think about the seal who's balancing like a beach ball on its nose, right? I'd like to think of the relationship between the humerus and the glenoid fossa in that way. So we can look at the golf ball and the tee, and we can say the tee is going to be that glenoid fossa, right? And then the golf ball is going to be the humeral head. So we can see already that glenoid fossa isn't large enough to kind of cup the humeral head and create that osseous or bony stability. Or we could look at it like a seal with a beach ball on its nose, right? In essence, that nose, or the seal's nose, is going to be the glenoid fossa, and then that beach ball is going to be the humeral head. And while these are probably exaggerations of the relationship, it certainly should allow you to see that we don't have the bony stability that we normally would have at most of our joints, at the tibial femoral joint, right? At the hip joint, right? At the ankle joint. We just don't have that even congruity between the two bones that are articulating. And so as such, we get lots of stability, and that's a great thing, but we certainly set our athletes up for more risk for instability issues. And so when we're thinking about glenohumeral instability, just briefly, we're going to talk about what that is and the etiology of it. But essentially the pathology is there's this increased laxity within the joint capsule, most often caused by stretching or laxity of the ligaments themselves. Remember, we said the ligaments are part of the restraint or part of what provides stability to the glenohumeral joint. But those ligaments become lax, and they can become lax for several different reasons. The first reason is going to be a traumatic incident happens, right? So either they dislocate their shoulder, and as a result of that dislocation, they essentially stretch the ligaments, and those ligaments become lax, and so we have instability about the glenohumeral joint. Or they could be born that way. And I like to think of our contortionists. So those individuals who just automatically are born with a lot of laxity within the actual joint itself. So you can either have it as a result of traumatic incident, or certainly could be something that you're born with, right? Some of us in this class certainly probably have more increased range of motion in the shoulder joint when compared to their peer counterparts. So in terms of the etiology, it can be acute and or it can be a chronic pathology. And we're thinking acute, we're thinking like a dislocation or a trauma to the shoulder. And then when we're thinking chronic, we're thinking like overhead sports. So our volleyballs, right? Our baseball pitchers or throwers who are throwing at a high velocity and causing a lot of stretching at the glenohumeral joint, right? And so then there are various types of instabilities that can be exhibited. And so they can be torn loose. I like to think of it as like torn loose, or they're born loose, right? And so that goes back to the acquired component, right? If they're torn loose, then essentially what we know about that is some type of trauma happened to the joint capsule, cause a stretching on that particular ligament, and so then there's injury to the joint capsule, right? But then they could also be born loose, right? And if they're born loose, essentially what that means is for some apparent reason they're born with a general laxity across the ligaments that stabilize that glenohumeral joint. Now, certainly within this torn loose spectrum, you could have individuals who over time are torn loose, right? And that would be micro trauma. So that goes back to those throwers, those volleyball athletes, those overhead athletes who are doing a lot of stretching across the glenohumeral joint. And in general, though, what we're saying is that there's some type of laxity. The historical question that we should be asking our patients who are in our clinic is, why did this happen, right? Did you wake up this way? Was it something that you actually did? Were you born this way and you've always had it, right? So those are the history questions that you're thinking about asking a patient who's sitting in your clinic with a glenohumeral instability. Now, there are 3 different types of glenohumeral instabilities, which could lead to one larger type. So you've got anterior instability, right? So if this is my shoulder, I'm unstable anteriorly. You could have posterior, which means I'm unstable posteriorly. You can have inferior, which means I'm unstable when you pull my hand, I move inferiorly. Or you can have a patient who walks into your clinic and has multiple directional instability. What that means is they're unstable maybe anterior and inferior, or posterior and inferior, or all 3 directions, right? So anterior, posterior, and inferior. You're not going to know that until you actually touch your patient and get into your assessment of the patient. But it becomes important to be considering in your historical questions, in particular when you get into the palpation inspection component of your patient evaluation. So here we are here, and if we're looking at the torn loose versus born loose, right? And we've kind of already talked about this, but is it because of a dislocation, or is it as a result of something that they're actually born with, right? We can all have a huge appreciation for contortionists and their ability to put their bodies in positions that we could never place our bodies in, right? So are they born loose? And if they're born loose, most of the times there's not much that we can do in the way of treatment except for to build strength around the joint itself. But in general, when it's torn loose, essentially what happens is these ligaments down here they get stretched, right? And if they're stretched and they're creating a tight, stable glenohumeral joint, when they become stretched, then that glenohumeral head is allowed to slide out of the socket. All right, so then our next pathology is going to be a glenohumeral dislocation. And most often the etiology or mechanism of injury is going to be forced abduction with an external rotation moment, right? And it's not just going into this motion. Just think about quarterbacks, right? Or if we're going up to run to give someone a high five and we bend their shoulder backwards, right? So there's a force, kind of a posteriorly directed force of the hand that leads to a glenohumeral joint dislocation. And what we know about most dislocations, I believe it's something like 85% of all glenohumeral joint dislocations are an anterior dislocation. And so the signs and symptoms, the number one sign and symptom is going to be that they felt a pop. And then they felt their shoulder giving way. And then they might have severe pain in the glenohumeral joint itself. And most often they're going to present to you in the clinic and their arm is going to be like right by their side. They're not going to want to move it. And another telltale sign is if we're looking at the deltoid muscles, what you will see in particular with an anterior shoulder dislocation is like the muscles in the back will be gone. If it's an inferior dislocation, you'll see kind of like a gapping and a disappearance of the middle deltoid muscle there. So you're going to be looking, you're going to be observing, right? You're going to be observing for shoulder posturing for sure. You're also going to be observing for do the muscles actually look the same bilaterally? And then the last question, historical question that we want to ask our patient is, what about numbness and tingling coming from either the neck, right, and going all the way down into the hands? In terms of management, I'm not supposed to tell you to relocate it, so certainly take this with a grain of salt. But most often when you send a patient to the ER and they have a dislocated shoulder, most often they're going to be sitting in that ER for 2 or 3 hours because they're not considered an emergent case, right? And so a lot of times when you are trying to assess the patient, just simply externally rotating the shoulder with a little bit of inferior traction will kind of do the trick and at least relocate them. And then you're going to refer them out to the ER just to make sure there isn't a fracture, especially if they're a first-time dislocator. You're going to sling them because that's a position of comfort. And then let's go ahead and get an x-ray just to make sure there aren't any fractures. So here's an example of one way in which your athletes can, right, suffer from a dislocation. So we can imagine that as they're diving for this football, as the shoulder, as this part of the arm hits the ground, certainly could suffer from a dislocation, right? We could also imagine if another player is flying, trying to tackle and hits this arm, certainly could suffer from a dislocation. I thought football, why not? It's applicable. We're living it. Some of you are already currently living this right now. And so this could be one way that a patient comes into you and tells you they've dislocated their shoulder. Other ways that you can see glenohumeral joint dislocations. So right here you can see, right? You can see that, what is that? The acromion, which you shouldn't, right? If that humeral head is sitting upwards like it's supposed to be, then you really never truly see the acromion shelf. And so this is a sign and symptom that that patient has dislocated. And then here, what we have is an inferior dislocation, right? So that patient's going to come off of the court, they're going to come into your clinic, and they're going to ask you to evaluate them, right? And so these are just different mechanisms of injury, but the most common way is for sure abduction and external rotation of the glenohumeral joint. All right, the sister to a shoulder dislocation is what's called a glenohumeral subluxation. So a dislocation is when a bone pops out of the socket and then stays out until it's relocated by a physician, by a practitioner. Subluxation is when the bone pops out and then goes back in, right? So it's very similar to a luxation or a dislocation. And the difference is the spontaneity or the relocation of the bone by itself without help, right? And so throwers experience subtle instability because of the throwing and traction at the glenohumeral joint. You see volleyball athletes who also suffer from instability. What we know about this is the dynamic stabilizers about the glenohumeral joint, in particular, the rotator cuff muscles, usually typically are stretched or lax, and so that increases laxity. Couple that with ligamentous laxity, and you're set up for repeat subluxations. Keep in mind, though, that one of the etiologies could also be an acute dislocation, right? An acute dislocation that causes the stretching of the rotator cuff, that causes the stretching of the internal ligamenture, and then essentially you have that laxity, and so that patient just continues to sublux. So what am I saying to you? That getting an acute dislocation and making sure that you are rehabbing it, making sure that you are strengthening all of the structures, will reduce the risk for subluxation in the future, will reduce the risk for the development of instability in the future as well. So signs and symptoms are similar to a dislocation. So it's going to feel like it popped out, but the difference is it'll pop back in and they'll be more functional than your acute dislocator whose bone is still out of its socket, right? They're going to complain of numbness and tingling or radiation, and that's because we're stretching that brachial plexus, right? And so they're going to have some numbness and tingling, but most often that's going to resolve itself, whereas in a dislocation, it's not going to resolve itself until the bone is repositioned. In terms of management, I'm going to say this, and I'm sure some of you are already there or will be living there in the clinical situation where it's all about strengthening the cuff muscles and the scapular stabilizer. So posterior, we have to stabilize the muscles that attach to the scapula, right? So when we're thinking about that's going to be our traps, it's going to be our lats, it's going to be our rotator cuff muscles, right? The list could go on. And then anteriorly, what we want to strengthen are our pec muscles, our deltoid muscles, and in general, the rotator cuff muscles, right? What we know about surgery for a repeat subluxer is that it's 80% effective. So there are 20% of the patients that will have a surgical procedure who still sublux, right? So it becomes instrumentally important for us as their clinicians to make sure we're doing everything we can to strengthen and to teach them to use their dynamic stabilizers so that they don't start the resubluxation process all over again. Okay. What do we know about instability, in particular repeat subluxing? What you see on this slide is the brachial plexus, and the brachial plexus emanates off of the cervical spine, right? And that brachial plexus then arises off of the glenohumeral joint and then goes down to supply both the humerus and the forearm and the fingers and the hand. So essentially that brachial plexus is responsible for all of the neurological signs and symptoms that we'll experience from the neck all the way down to our fingers, right? What happens with an instability a lot of times is as this continues to get stretched, or if we sublux a lot, then we can impinge upon the brachial plexus, right? And so then not only do we have a weak glenohumeral joint or an unstable glenohumeral joint, but we now have a humeral head that's impinging or pressing on the brachial plexus and is causing numbness and tingling. And then the terrible part about the numbness and tingling is the weakness that exists at the hand, right? So that athlete loses the ability to grip, to hold the ball, to throw a curve ball because they can't grip really well because they have the numbness and tingling that goes all the way down into the hands and the fingers. And so it becomes important to look at a dislocation or a subluxation on a larger scale, right? Not only is it going to impact the shoulder, but it's going to impact the arm, the upper arm, the lower arm, and then the hands and the fingers, which can have deleterious effects for student athletes across the spectrum, right? From our golfers who have to hold a golf club, right? To our baseball or softball athletes who have to have a good grip on the ball in order to make it do what they want it to do. So those are things to keep in mind as we think about these pathologies as a whole. And so this is a great cadaveric dissection. I guess I'm challenging you all a little bit, but this was done by a student in the program, and so you can see this beautiful dissection right here of the brachial plexus, right? And you can see how that pectoral muscle right here and that glenohumeral head, right, if it's loose and it's allowed to slip out, will certainly impinge upon that brachial plexus and cause the numbness and tingling that's most often associated with instability, with a glenohumeral head dislocation and subluxations. So let's talk rotator cuff strains versus a tear, and put myself over here. So in terms of the etiology, most often it's going to be a chronic impingement that occurs over time, most often seen in our overhead use sports, particularly it's going to be baseball that's going to be plagued by this pathology most often. It certainly can be traumatic in nature, but again, if the traumatic rotator cuff strain or tear is extremely rare. I want to say this to you guys because I've heard it diagnosed so many times in the field and it's just not true. What we know about actual tearing of the rotator cuff is that typically doesn't happen until patients reach the age of 40 or over. So if we have a patient coming into our clinic who's presenting with rotator cuff signs and symptoms, most often it's probably a strain, not a tear, right? So there's probably fraying of the fibers, but not a full-blown tear. Full-blown tears just don't happen until we get older in life. So we need to be thinking with that lens when we're evaluating a patient who has a rotator cuff strain. Again, it's most often caused by repetitive sports such as baseball. And if you look at this image down here and below, you can see just how much torque is on that glenohumeral joint. So it would make sense that we certainly should have lax rotator cuffs, and it is possible that we could certainly strain that, in particular in our higher level sports where there's a high amount of velocity coming through that glenohumeral joint. So in terms of signs and symptoms, they're going to be similar to impingement, and the difference is that they're going to have weakness with strength testing. And so there's this test called the empty can test, where you have that patient stand right about here, so 90 degrees of flexion, about 30 degrees of shoulder abduction, and your job with your thumb down, it's called an empty can because when you turn your thumb down, you empty out the can, right? You're going to press on their ulna, and if they fall down towards the ground, then that's a positive sign for a rotator cuff strain. So again, that's an empty can test. If it's a tear, the differences between a strain and an actual like tear per se is the night pain. Most often with a complete tear or rupture of the rotator cuff, they're going to have that night pain, whereas with a strain, they're going to have pain with activity. They might have pain after activity, right? But usually that pain will resolve itself and go away. So want to use a rotator cuff test. The empty can test is a good test to use. Again, you'll learn these in upper extremity. Right now I'm just giving you signs and symptoms. This isn't really a special test or a rehab lecture. You'll get those, but if you have questions, certainly feel free to reach out to me and ask. In terms of management, it's pretty simplistic. So we're going to rice that patient, and then we want to strengthen. So here's the thing. A lot of times with rotator cuff, we always assume that the rehab should be heavy weights. But in fact, what we know about the rotator cuff is it only takes about 3 to 5 pounds of weights to stimulate them. So you could do high reps and low weights and truly strengthen the rotator cuff muscles. Now, if you want to strengthen the deltoids or the pecs, certainly should use a higher amount of weight. But if we're talking about the rotator cuff, so supraspinatus, infraspinatus, teres minor, subscapularis, they only require about 3 to 5 pounds of weight to stimulate and strengthen them. So we should be considering that in our rehab paradigm. If it's a complete tear, then clearly they're going to require surgery. But again, complete tears are relatively rare in our younger population. And so if you're going into physical therapy and you're working with older patients, then most likely surgery would be imminent. But again, with younger patient populations, you just won't see a complete tear in the rotator cuff. All right, so here is that empty can test that I was referring to. So you guys can see how that patient is at 90 degrees of flexion, 30 degrees of abduction, and that clinician is going to be pressing down on both arms. And you do this at the same time to compare strength on both sides, right? So that downward pressure is going to be applied, and then what we're basically looking for is whether or not that shoulder actually falls down to the ground, and if so, then you're concerned, right? You're concerned about whether or not the supraspinatus of the rotator cuff muscle group is compromised, and if so, then we refer out, get an MRI, make sure it's not torn. And if it's strained, then we're going back to those high reps, low weight to strengthen the rotator cuff. All right. The next pathology that we're going to talk about is going to be biceps brachii tendonitis, not necessarily a strain per se. Those are very rare, but tendonitis can happen in your throwing sports, and you might not be in throwing sports currently, but you will get there eventually. Most often the etiology is going to be like chronic throwing, so repetitive throwing, and it's the eccentric contraction when we slow down the elbow. So it's not the here phase, it's the here phase that does it. So it's like that eccentric contraction of the elbow that will cause the straining or the tendonitis that will happen. Pathology wise, what we're thinking about is it can range from mild tendinopathy to a complete rupturing of. So we hope that the rupture never happens, but in terms of the grades, remember grade 1 and grade 2, we're thinking that patient's probably just going to have pain like during, maybe a little bit after, which could progress to pain before, during, all of the above. And then a complete rupture would mean they're just completely dysfunctional 100% and they can't perform any part of the sport. And so you can have a rupture, right, distally, or you can have a rupture of the longest tendon, right, proximally. So it can happen on either end of the spectrum. In this particular case, signs and symptoms would be you would have palpable pain in the bicipital groove. So right here, see that right there, right where that biceps long head tendon goes. But if it's distally, you would have palpable pain right here in the cubital fossa of the elbow, right? More rare tendinopathies, tendinitis most often happen to the longest tendon or to the short head of that tendon up here on the coracoid. So here we are. So we're thinking with the biceps brachii strain or tendinopathy, right? Here is the long head, the tendon of the long head. And so remember I said there would be tendinous palpation in that bicipital groove. Here's the bicipital groove. So I'm just kind of giving you like this image, this distinct image. Here's the proximal portion of the humeral head. Then there'll be this groove, right? And so it's this component right here that develops the tendinitis most often. And most often treatment-wise, you're going to have to do some kind of cortisone injection, some type of soft tissue. It just really depends on the patient's signs and or symptoms. Okay, very briefly, we're going to talk about traumatic injuries. The first traumatic injury we're going to talk about is a clavicular fracture, because I'm sure you'll see this in your lifetime this semester. So in essence, this is a clavicular fracture down here. You can see that this part of the clavicle is disjointed from this part, and so the fracture is occurring right here. Most often fractures to the clavicle take place where the bone is changing its shape, so midway between the actual bone itself. In terms of the etiology, it's a direct blow to the clavicle, or sometimes it's landing on, so if I fall and I land on my acromion tip and the forces are directed to my clavicle. And the other way that it can happen is through what's called the fouche, so falling on an outstretched hand, right? So if I do this, basically, so if I were to fall down and I use my palm to catch me, right? If you do that, then forces could be directed up the ulna and radius, right, all the way to the clavicle, and of course it could lead to a fracture. So there are multiple ways in which the clavicle can be fractured, and like I said, it's usually going to occur right where the bone is changing its shape. So I'll get a little bit closer. You guys can see here, this is the start of the bone, and then right here, if you do that on yourself in your chair, you'll see this is where the bone is changing shape, and so that's where it's most susceptible to a fracture. In terms of signs and symptoms, here are two that I think of when I think about clavicular fracture. Number one, the athlete's going to be supporting his or her arm, and then the athlete's always going to tilt to the side of the injury to support the injured side. So if a patient walks into your clinic like this, you're suspecting clavicular fracture. There certainly will be deformity, but it isn't always as obvious as what you see below. You might just have to palpate and feel a divot, or what's called a piano key sign. So you'll press where there should be a bone and there isn't. And then there's all the other signs and symptoms that are very common to other pathologies of the shoulder, which are deformity, pain, and swelling. So I would say the top two signs and symptoms: tilting the head towards the side and the splinting of the arm. So how do we manage this? We splint them and we refer. So we sling them and we refer. And so you'll learn that in your first clinical class, which is dealing with emergent pathologies and or injuries. But you're just going to sling them and refer them out. And what we love about the clavicle is it typically, even when they look like this, they can resolve themselves. So they don't necessarily need surgery. They might have to be immobilized for 6 to 8 weeks, but they don't always require surgical intervention. In fact, the surgical intervention is extremely rare, but certainly could happen. And if so, then they just go ahead and pin the two bones back together. So here are some things that they will do if you have a clavicular fracture. So let's take a look. Number one, you see the clavicular fracture here. What they'll do is they'll put you in this figure 8 brace, which I alluded to on the other slide. And so essentially that figure 8 brace, you see what it's doing? It's pulling me back into this position. And by doing that, guess what you're doing? You're realigning that fracture, right? And it's also teaching me good posture, because what I'm going to want to do to make myself feel better is this. But if I do that with a fracture, then those bones kind of cross. And so that figure 8 pushes us here, right? And allows that bone to align. So if your patient wears this consistently, most often they don't need surgical intervention. Okay, the next pathology is an acromioclavicular sprain. So we're looking here for palpating the SC joint. If we sweep up to the top of our shoulder, this is the AC joint. The etiology is exactly what you see in this image. So it's falling directly on the acromion, but it also could be falling on an outstretched hand. So there I fall and I use my hand to catch me. And so if my clavicle doesn't get it, then my AC joint or my acromioclavicular joint gets it. Now, there are several different grades of acromioclavicular sprains. You can see them here. But if we're looking at this, right, this ligament right here is a ligament that's responsible. The acromioclavicular ligament is responsible for holding the clavicle to the scapula, right? And so you've got the acromion of the scapula, and then the clavicle, which is how you get the acromioclavicular joint. And then there's a ligament, the AC ligament, that is holding those two together. That's what gets compromised when we have a sprain. So in terms of grade 1, they're going to be point tender, but they have zero deformity. So you touch the joint and it hurts, but no deformity. With a grade 2, they have loss of range of motion. Most often it's in shoulder abduction. And they'll have a slight deformity. So you could see the clavicle poking up. You could maybe push on the clavicle and it's more lax, so you have more movement. And then a grade 3 would be like a true gross deformity, like you see movement of the clavicle when you squeeze or when you touch it. And then they have what's called the positive vice grip. So imagine this, right? This is a knee, so ignore that part. But if this were the acromioclavicular joint, a vice grip is when I put my fingers together and squeeze that joint. So if I were to take my hands and put my hands here and here, I would squeeze that AC joint with what's called a vice grip technique to see if there's movement of the clavicle. And so there would be a positive vice grip. So what is the Fouché? Because I've mentioned it a few times, and in my undergrad course, I use this image, and I think it's the perfect image, right? It's an idea that I'm going to slip and I'm going to fall, and oh my gosh, I'm going to put my hand out and use it to catch me, right? And so when I put my hand out and use it to catch me, what we can see is that as I use it to catch me, right, all of those forces are being directed right here to the acromion, right? And if they don't get directed to the acromion, then they're traveling down to the clavicle. This is why the Fouché, we're going to talk about other injuries that happen as a result of the Fouché, is a deadly mechanism of injury. And I know most times when we fall, we're always like, oh yeah, I'm going to do this to protect. But in fact, it's the worst thing that we could do. So that's the Fouché mechanism that I've been referring to this whole entire time. As we're looking at all of these images, let's go ahead and take a look at what different kinds of AC joint sprains you can have, right? And so we can obviously see this more as a grade 3, certainly, right? And then if you're looking at this figure here, it could be almost like a grade 2, certainly could be a grade 3 for sure. And then this 2A is for sure a grade 2, where you kind of have, do you see that upward progression of the clavicle? And then figure 1 is just a mild sprain. So you maybe have a little bit of swelling, you get some tenderness, but definitely no movement of the bones per se. But you got swelling, and so then you have tenderness to palpation, right? So these two probably are the worst case scenarios. So you've got that rupturing of the ligament, but that bone is still pretty aligned. But here, you certainly have rupturing of the ligaments, and then you have an upward projection of the clavicle itself, and that's what we don't want. That's when you sometimes have to go in and intervene and have that surgical intervention. So here's an example of an AC joint sprain. To orient yourself, this is the shoulder or the outside of the arm, and then this is the clavicle. So you can see that there from a patient perspective. All right. And then if you look here, right, here's collarbone. And then what do you have here? You've got the clavicle, right, sitting upwardly as well. Okay, so then you have the sternoclavicular joint, which is here, right? The mechanism of injury, anyone want to guess? It's a Fouché, right? So here. So many pathologies can occur from a Fouché. We have the sternoclavicular joint, we have the AC joint, we have the clavicular fracture, right? And that's just in the glenohumeral joint or shoulder region. There are other areas that are impacted by that mechanism as well. In terms of signs and symptoms, most often tenderness to palpation for a grade 1. But then grade 2, grade 3, you're actually going to get movement of the clavicle closer to the sternum. So you can see that here, right, as that clavicle will progress out of its resting space. Now, the concern is with a posterior dislocation, because the posterior dislocation, if it dislocates posterior, can sometimes impinge on the lungs or even the heart. And so anterior dislocations we're okay with, but if it's a posterior directed dislocation, then we refer out just to make sure they don't have any type of pneumo or hemothorax associated with that. They will also lack or be limited in a shoulder abduction. So here, right? And why would that be? Because as I get into an abducted position, what's happening? I'm compressing that joint. So they won't like that very much at all. And so in terms of management, you're going to protect it, rest it, ice it, compress it, and elevate it. And then you're going to do what I suggested with all of the other shoulder pathologies in this lecture. It's all about strengthening the surrounding structures, right? So in this particular case, I'm going to be strengthening the rotator cuff, probably my pecs for sure. Might even start strengthening the sternocleidomastoid, the scalenes, right, to help kind of stabilize this joint, right? If it's a 3rd degree, so ligaments are ruptured and you're seeing either an anterior projection or too much of a posterior projection, then you're referring out to make sure that patient doesn't need surgery and to make sure, again, they don't have that hemo and or pneumothorax. That concludes our slideshow. Those are the most common shoulder pathologies. You'll get more shoulder pathologies for sure in another semester, but these are the ones that you're going to see most often. So being able to recognize them, being able to take a good history to figure out where is it, if it's a FUSH, is it AC joint, is it clavicle, is it sternocleidomastoid, is it, oh my goodness, the sternoclavicular joint. What is it that's being plagued by this mechanism of injury? Or if I have radiculopathy in my fingers, right? Is it impingement? Is it my rotator cuff? Is it a subluxation? Is it a dislocation? So these are all of the pathologies that I project that you'll see in your clinicals in the first few weeks. If you haven't already, you probably will. So I hope this has been helpful to think about etiologies and at least common signs and symptoms. Look forward to seeing you guys soon.